Michael Morley Lecture Awardee.
Great. Thank you, Charlotte. Thank you, Karthik. Can I just take this opportunity to thank you all for attending and thank our excellent chairs for today for putting together such a vibrant session. It's my pleasure to tell you that this is actually the highest attendance we've ever had for a UKMS Education Day. We are full, as many of you at the back will know, and we actually had a waiting list, and there's about 80 or 90 people online. So it's credit to you all and credit to our organisers. So moving on to the Michael Morley Lecture, this is one of the most prominent parts of our Education Day. Michael Morley was a patient with myeloma who sadly died in the early 2000s, and his family set up a foundation which continues to support the UKMS. And it's my pleasure to introduce Dr. Paola Neri from the University of Calgary in Canada. Paola is a associate professor of medicine and also a hematologist at this centre. She's been there since 2008, having initially trained in Catanzaro in Calabria in Italy and completed her medical training and her medical oncology in the same city. Between 2003 and 2006, Paola moved to Boston and worked with Dr. Ken Anderson at the Dana-Farber Institute. She has many research interests. She's extremely highly published. She's received grants from both the IMS, the MMRF, and the Leukemia Lymphoma Society. And her main research interests are in translational myeloma, particularly genomic studies, identifying mechanisms of drug resistance, and therefore looking for novel targets. I know Paola is going to give an excellent talk. She's going to talk to us about opportunities and challenges in immunotherapies with myeloma. Thank you very much.
Thank you very much, Sherry. It's really, I'm very grateful for the opportunity to be here. Thank you, the organizer, for that. And of course, it's always an opportunity to see friends and colleagues in the myeloma space, but also to meet many of you that, again, they are doing research and see patients with myeloma. So I've been, as Sherry mentioned, I will chat about the opportunity and challenges in immunotherapy in multiple myeloma. This is my disclosure slide. So I would like to start with this graph that really tell us what we have done so far in terms of therapy and also improved survival for our patients. You can clearly see in the last 20 years, the overall survival at 5 years of our patient went from only 35% to doubling already in 2020. And this is where we start using now T-cell therapy. So for sure, the future is bright because we can see that survival of our patient improving significantly with time. Now, this is, of course, a result of the much more understanding of the pathogenesis of the disease. This cartoon wants to illustrate what we know so far about myeloma, what allows myeloma cells in the bone marrow niche to grow, to escape the immunorecognition. And of course, I don't have much time to describe the figure, but I'm sure many of you are familiar with the ability of the myeloma cells to produce cytokine, growth factor. They really allow the cells to grow, allow the cells to escape immunorecognition by, for example, inhibiting the recognition of a AP cell, like dendritic cells, or as well as of impairing the ability of an NK or T cells to recognize and kill. And because we know much more about this mechanism of escape, then now we have different way to harness and, of course, to allow our immune system to recognize the myeloma cells. This is a very general overview that really describes the different way we can now stimulate the immune system against myeloma. You can clearly see we have now a monoclonal antibody able to recognize target highly specific on the myeloma cells. And of course, daratumumab is an example of that. We have also ability to restore an immune suppression by, for example, using checkpoint inhibitors that I will argue is not completely over. Their use is not completely over in myeloma. And of course, we have the CAR-T that will spend a little bit more time. There is also the role of vaccine that we are exploring. They are not at prime time yet, but I will argue is also an area where we could probably utilize in the future for myeloma. And probably what is probably most exciting is the fact that there are now drugs that we currently currently used in myeloma, like immunomodulatory drugs, as well as the proteasome inhibitor, they are really known not only to have an anti-myeloma effect, but also to have an immune-stimulating effect, as demonstrated in this figure. Of course, time constraint limit my ability to describe all of these mechanisms, but I will argue that probably the most excitement comes by the use of T-cell-based therapy, and this includes mostly the use of CAR-T and T-cell engager. Now, many of you are familiar. I just point there the two products approved for myeloma. One is ide-cel, cilta-cel. Both of them are CAR-T of second generation, so we know they are known to have this extracellular domain that made of a single chain fragment, variable fragment that bind one or two epitope in the BCMA surface. There is a transmembrane domain that is good for the stability of a CAR. And of course, the intracellular domain is where most of the change for the CAR-T are coming, because it's where actually is what trigger a T cells recognition and killing of the myeloma cells, and showing here is the presence of 4BB1, which is the co-stimulator often used for this product. One mention, of course, CAR-T so far has been mostly is an autologous approach. Patients are, we use their T cells to create, again, to introduce the CAR, and then eventually reinfusing the patient. But we know that require time, so there are 4 or 5 weeks that comes between the harvesting the T cells and eventually have CAR-T ready to go. Therefore, it's very important to have another strategy, which is the T-cell engager, where actually the protein are already made available off the shelf. And what this cartoon shows, of course, their ability to bind two different antigens at the same time. One, of course, on the CD3 of the T cells, and the other one, that either a GPRC5D, BCMA, or FCRL5 on the myeloma cells. But I will argue they are not all the same, and we'll go back to this point later on during the presentation, where you can clearly see, even if we have several anti-BCMA, for example, T-cell engager, they are different. Some have what we call a monovalent target binding. This is the case of Tecli or lanatamab. Others have a bivalent target binding, and I'll show you how this is relevant when we talk about overcoming resistance. Similarly, for GPRC5D, we have talquetamab, which is a monovalent target binding domain, but also for Intamib, which indeed has a two bivalent, so ability to target two epitopes at the same time. FCRL5 is the only, actually Cevostamab is the only drug, antibody able to target FCRL5 so far, and there's a monovalent target binding domain. Now, the importance when we talk about T-cell therapy is, of course, target and something on the cells is very specific, although we know that GPRC5D, for example, is expressed on the keratinized tissue, and therefore their safety also is something we need to monitor on the safety point of view. Now, why we're excited about this therapy? Because if you think about what we had before BCMA therapy was very limited. If you think about the result of, for example, the mammoth, this academic study in patients that were triple-class refractory, so refractory to either a PI, an IMiDs, or an anti-CD38, their PFS was very poor, 3 months, and overall survival only 8 months. And this was the case also if they were, of course, penta-refractory, so resistant to 2 PI, carfilzomib, bortezomib, 2 IMiDs, POM, lenalidomide, and of course CD38. But even if you look at the patient that were only triple-class exposed, these are results from the locomotion trial, this also PFS was very minimal, 4 months PFS and 12.4 months. So you can clearly see how poorly we were doing before this therapy were available to us. Now, let's look at the exciting data we have now with the CAR-T. So this is the first phase 2 trial, the KarMMa-3, that was performed to test the ability of the ide-cel anti-BCMA CAR-T in triple-class refractory patient. So you can see that the response rate were significantly higher. We have now response in 73% of the patient. The PFS was around 8 months, but if you look at the patient, for example, receiving CR or stringent CR, was also up to 20 months. So you also are aware of the phase 3 trial when compared to standard risk, where the PFS is around 11 months versus 4 months in the standard of care arm. But probably what is really most exciting is see the result of the cilta-cel, which if I remember, I told you earlier as dual binding to BCMA. And in my mind, this is part of why it's also more effective. But what you can see, again, triple-class refractory patient, result of the CARTITUDE-1, so in patients that they have more than 3 lines of therapy, very impressive response rate, 97%. CR rate 82%, but what was probably the most exciting thing, you see probably the publication in JCO, a third of these patients in more than 5, with a long-term follow-up of more than 5 years, they are doing extremely well. You see this plateau line that make us think that we may cure some patients if you use this therapy, but of course we need to see that in the real time. This is CARTITUDE-1, so in relapsed refractory myeloma patient. What about if you use this therapy in early line of therapy? So in patient with 1 to 3 line, this is the result of the CARTITUDE-4, and was very impressive. We see data at ASH as well, where at 33 months, almost, again, 3 years, we still have a PFS and overall survival no reach. You can see that on the lab, on panel A, almost 60% of patients doing very, very well, still at 30 months cutoff, while patient receiving standard of care. Standard of care is mostly Dara-PD, Dara-Valke-Dex, having PFS of only 25.7% at this month, 30 months PFS. If you look at overall survival, again, no reach versus a standard of care of 63 months. So definitely impressive. And if you look at MRD negativity data, these are 10-6, 10-5, clearly bigger difference in patient receiving cilta-cel in 1 to 3 line of therapy. Now, the space of anti-BCMA CAR-T is, of course, evolving. I want to just show you a few. Another product is the anito-cel. We have seen data at the last ASH meeting. This is different of the other anti-BCMA CAR-T I showed you earlier, because it's second generation, but it's a very novel D-domain binder, which is a small synthetic binder that allow 2 things. One, allow more T cells to express the CAR and therefore to recognize the cancer cells. And on the other side is what we call a fast off release that allow the T cells to recognize quickly the tumor, but doesn't really, they reduce significantly the safety or the cytotoxicity. And indeed, in very heavily pretreated patients, more than 4 lines of therapy, you have seen a median PFS of 30 months and overall survival no reach. And if you look at what they have reported as well, 80% of patients already in CR, stringent CR. And what is probably unique, and I'm sure you have a session about safety later on today, is the fact they don't see any neurological toxicity. And again, in my mind, is because, again, this off-release, fast off-release, that really allow the product to work, but then get really detached from a T cell. So no much safety has been raised by this product. Talking about another target, we have an anti-GPRC5D CAR-T. This is Arlo-cel. They've been presented, actually updated a few months ago at the UKMS, where in patient with relapsed refractory myeloma, more than 3 lines of therapy, you see a response rate quite high, 94%. I will argue we still need a longer follow-up, but it's a product that shows PFS of 12 months of 75%, and there is a lot of ongoing response. I'm sure many of you are probably part of the trial. There is a phase 3 plan with this product, which seems to not be causing a little bit of neurotoxicity, and this is an aspect that we need to get more data as well. Now, moving on to the T-cell engager, I just intentionally put them all together in this table because at the end of the day, even if they are different, clinically, they perform very similar. So these are a result of putting them together as a single agent when used for the first time in patients with at least 5 lines of therapy, so multiple refractory patients. Most of them were triple-class refractory. But the point I want to make on this table is that we see a year and a year half of PFS and a response rate from 60 to 80%. Of course, it's the case for talquetamab, which is the only GPRC5D eventually available, and cevostamab, which I know is still not approved in many countries, including Canada as well. So with this in mind, considering that even if we were happy about the result, we know we could do better. And in fact, we start seeing now combination approach. For example, we are seeing, this is presented at ASH last year, the addition of taclizumab, so anti-BCMA in combination with DARA and anti-CD38 and IMiDs. These are just a quick result on Majestic 2, TRIM2, where you can see in patients receiving 1 or 3 lines of therapy or more than 3 lines of therapy, quite high response rate. Altogether, the overall response rate is 85%, but what I think is very encouraging, seeing this PFS still not reached in many cases, especially if we use this therapy in 1 to 3 lines of therapy. So very rapid and deep response that seems to be durable so far. And so we're not surprised then if we see now combination of talquetamab in combination with DARA and LEN. In patient, this is a work presented by Ajit Nuka from Emory, in patient this time newly diagnosed, where the addition of an anti-GPRC5D with an anti-CD38 and IMiDs show very impressive response rate. We have a long way to go with this just relatively short follow-up, but this seems to be very encouraging. So a lot to come in the space where we combine one target with other approaches. What about now one trial that I want to mention because it's very impressive. So now we're seeing this anti-BCMA T-cell engager being moved really, really early on. This data from the Majestic 5 or GMMG HD10, the Mark Rapp from Heidelberg is running, just presented at the last IMS meeting. What they are doing in this trial, they're using in induction 6 cycles of either TECLI-DR or TECLI-DR with different schedules, or TECLI-DVR. I know it's hard for us to use it in clinic, but it's good to see that these data are very impressive. But what they are seeing already after 3-6 cycles, not only patients are in CR, they are MRD negative, like -5, -6, so very impressive. They also report safety profile, which is also encouraging, and apparently no issue on collecting cells to perform the transplant. So we'll see in the long run what the play out of this drug, but exciting to see that being moved all early on, even newly diagnosed. Of course, I cannot stop the clinical part without discussing the 2 pieces of data we have with the trispecific. Now there is an attempt to use at the same time a drug that they're able to target 2 antigens at the same time. So this is work that Niels van den Donk have shown at the last ASCO meeting a few months ago, where they report data with the BCMA, GPRC5D, CD3, trispecific, J&J 5322. It's hard to not be impressed by this data. So the response rate in patients, especially BCMA, GPRC5D naive, are outstanding, 100%. If you look on the right, the PFS is 12 months PFS of 95%. The recommended phase dose seems to be very incredible. Of course, we need time to see longer follow-up if we maintain this persistent, but so far impressive, especially again in naive patients not exposed prior to other BCMA or GPRC5D therapy. Of course, there is another trispecific that we just presented at the last IMS meeting based on the Trinity-1, which I heard that you also have active in many sites here in the UK. In this case, this is an antibody going after BCMA, CD38, and of course CD3. What is unique about this trial that they have shown very small numbers, so we have to recognize the low number of patients, but no DLT identified, response rate of 74%. They are durable so far. They have some patients even a year out from using the drug, but what is the good part, I think, and exciting from my point of view, the fact they also see response in patients with extramedullary disease and high risk. Of course, we need to see, even in this case, longer follow-up and see if this results are indeed durable. Now, going back to reality and going back to the fact many of us are using this therapy as a single agent in relapsed refractory myeloma, I think we all have in our mind patients that either don't respond to therapy, they have what we call primary resistant, and this can be high disease burden, high soluble BCMA, or extramedullary disease, or quite often we have what we call acquired resistance. So initially patients respond, and often after a year and a half, they progress. And this summary, this cartoon really comes from a review that we wrote last year, where we tried to put together what we know so far about the mechanism of resistance, which will be the focus of the second part of this presentation. Now, our lab has really focused in the last 10 years to understand what causes resistance to this therapy. So what are the factors coming from the tumor? Or is the microenvironment relevant for T-cell therapy? What are the T-cell factors? And to answer this question, we have really created a tissue bank where every patient receiving this therapy gets a sample collected prior starting therapy, at time of best response, at time of progression. And this cartoon just shows you how we do process the sample. Of course, every bone marrow and peripheral blood, because we try to collect both when possible. Following the FICOL gradient separation, get used to create to go through the magnetic sorting of either tumor cells using CD138 magnetic beads or CD3 to select the T cells, and of course all the bone marrow negative get also stored. And what we do in the tumor, so CD138 positive cells, we perform a whole genome sequencing looking at the genomics. We have also single cell RNA-seq. I'm going to show you also some data on single cell CMV, which was available before with 10x, now is just inferred from the RNA-seq. And on the T cells, I'll show you data using single cell site-seq and TCR repertoire. Starting with the CAR-T, we know, for example, from other group, and this is work from the Max Merz from Germany, that the expansion of CAR-T is what really matters in terms of to predict response to CAR-T therapy. This is the case for ide-cel and cilta-cel. And what is really different between the two products is with the ide-cells, we see this expansion early on, 7 days, and persists 14 days after the infusion. With the cilta-cel, this response is happening a bit later, but it's still more enriched in patients they are responding versus a non-responder. But of course, what is really unique about what really influences response to CAR-T is mostly the T-cell phenotype. This is work that group from Janssen has presented at the last ASH, where they look at the PFS of patients receiving cilta-cel, just looking at the phenotype of the product. And they clearly see that patients doing the best are the one they are enriched by a subset of T cells than product. They have what we call stem-like phenotype. You can recognize they are TCF7 positive, left positive, CCR7 positive, and these are the one you can see on the red line doing extremely well. In contrast, we're learning that if in the product we have Treg, CD4 FOX positive cells, and again at the transcriptomic level, these are patients, they don't do well, not surprising. We know that Treg are the bad player, and in fact, if they are present, the product can affect the efficacy and the persistence of our CAR-T for patients. We have also looked ourselves for patients receiving ide-cel as part of the clinical trial. This is work where we collect the T cells of this patient. Some we knew were sensitive, are indicated here in blue. Others are resistant, indicated here in yellow. And we perform site-seq. So we look at the transcriptomic as well as the immunoprofiling of the T cells. And even if you're not familiar with the T-SNE plot, you can clearly see the two groups really cluster differently. In the sensitive, we see an enrichment on the top of cells. They have CD45 RR positive, CCR7 positive, CD28 positive, so they are more stem-like central memory T cells. In contrast, the resistant patient, you can see they don't express CD28, they express CD57, they are CD45 RR positive, and then when we look at the inhibitor receptor, not surprising, the resistant patient showing here in red much higher level of PD-1, LAG3 and TIGIT, suggesting that indeed these T cells seems to be more resistant, more exhausted from the phenotypic point of view. We are also learning, this is what we just presented at the last IMS meeting, that the rest of the microenvironment is indeed important for this patient. If you look at the responder here in blue versus the non-responder in red, you can appreciate if you look, for example, at NK cells showing in panel A, the sensitive are enriched of NKs, they have a cytotoxic profile. They express activator receptor and they lack inhibitory receptor. Similarly, they express CDC1, CDC2, so two important class of dendritic cells. They lead to a type 1 and type 2 immunoresponse. And in red, I highlighted the fact, for example, in non-responder, we see an enrichment of plasmocyte dendritic cells, monocyte. They are mostly non-classic with all the inflammatory signal, suggesting that indeed if we have an inflammatory bone marrow microenvironment, these CAR-T really have our time to perform or to last for our patient. What about the T-cell engager? So a few years ago now, in collaboration with a group of Heidelberg, we showed that the landscape of T-cells at baseline really influence how patients respond to this therapy. This work was done by performing single-cell RNA-seq and TCR repertoire analysis on this patient, and we were able to collect patient sample at different time points and track the expansion of the clonotypic T-cells over time. And the first information we learned from this work is that, first of all, the T-cell engager induce expansion mostly of the CD8, not the CD4. And just show a few data of this paper, we see this expansion of clonotypic T-cells, that they are more present in the responder versus compared to the non-responder, but the major difference is the subset of T cells where this clonotypic expansion was happening. What I mean by that, in the non-responder indicated here now with the blue arrow, we see this clonotypic expansion happening mostly in T cells. They are TOX positive. They are also CCR7 positive, as well as positive for all the inhibitor receptor. In contrast, they are in the responder, we mostly see the increase of this clonotypic extension mostly on the CD8, they are effector, they are 6 or 7 or 1 positive. So indeed, it's really where which subset is enriched in this patient that really dictate the response. And in fact, we also look at baseline, if we're able to predict based on just a baseline bone marrow expression of these T cells in patients receiving therapy, if they have a very high level of exhausted T cells, so dysfunctional T cells, TOX positive, unfortunately, these are patients that will not do well even with this therapy. Now, the concept of T-cell exhaustion, it of course is a work in progress. Many of us believe it's existing, but it's probably not the major factor, rather they call T-cell dysfunction. And I want to show you that in addition to looking at the exhaustion or dysfunctionality from the transcriptomic point of view, it's very important to use functional study to really call the exhaustion status. And I want to share with you two cases actually coming from the clinic. So we have established in the lab a simple way to check if the T cells of patient are indeed exhaustion or dysfunctional. So this is in this study we collect PBMC of patient, and then we co-culture them at the ratio 10:1 for 2 days with the OPM2 cells, which we know express BCMA. And we use healthy donor to prove that the test indeed is correct. As what you can see in here, that of course at baseline, you see a lot of cells that they are actually before starting therapy with the ERLA or the different anti-BCMA, they are all alive. Of course, as soon as you incubate them with different dose of ERLA, different time, these cells are all killed. In contrast, look at this patient. These are PBMC of a patient who actually progress after anti-BCMA T-cell engager after really 4 months, and indeed you can see there is no killing. All the myeloma cells are still happy, and this is by flow cytometry test we can do clearly. So a patient that we knew at transcriptomic level was called T-cell exhaustion, and by functional testing, we are proving that indeed there's a T-cell dysfunction. As a different case is this other case where actually a patient progressing on an anti-BCMA therapy who actually received an anti-GPRC5D, in this case actually responded to therapy. You can see that the effect of ERLA, again in the healthy donor, of course, kill most of the cells, but this patient actually in the presence of these different anti-BCMA T-cell engager was able to kill the myeloma cells. So it's a patient where eventually after one TC, we can think about using another maybe with a different target, because indeed their T cells are functional. So I will always argue that to call T cell dysfunction, we cannot just use on transcriptomic data. We need to have some functional study. Now, T-cell dysfunctional fitness is one part of the story, but I want to show you this case of a patient that we thought T-cell dysfunction was the cause of resistance, but was not really the case. This is one of our first patients treated with the anti-BCMA CAR-T in our center, was 4th line of therapy. He received initially responded, no surprising, lasted for almost 8 months, and then what we did, we immediately used an anti-BCMA T-cell engager. You can clearly see by looking at the monoclonal protein, didn't respond at all. So 2 effective therapy, but one partially effective, the other one absolutely no response. So we, of course, look at the T cells of this patient, thinking that T cell fitness was the cause of the resistance. And you can argue that even if you look at the CAR-T of this patient, identified here, they have a good ratio CD4-CD8, they have a good expression of CD28, they don't express CD57, good expression of CD45 ARRO. So we really could not say that the T cell fitness was the cause of resistance. And indeed, when we did more work on the tumor side, we actually biopsied the plasmacytoma that he developed on the pelvic area, we noticed that when we performed genomic analysis, these are single cell copy number analysis you see on panel A, the tumor was really different at time of progression. In addition to different changes of the different chromosomes, I want to point your attention to panel D, where you can see pre-therapy and post-therapy, the presence of a biallelic loss of BCMA, the chromosome 16. There was not present prior starting therapy, and unfortunately was the major clone at time of progression. And this was, of course, confirmed, the lack of BCMA was confirmed by flow cytometry, and of course by mRNA level. So we basically use another anti-BCMA without even thinking to check if BCMA was expressed. So it didn't respond to T-cell engager therapy because the target was not there. And indeed, we have now a better sense of what, from the genomic point of view, cause resistant post-BCMA. We have cases, and this has been reported by other groups as well, of biallelic loss of the target, or the cause of resistance can be the presence of this minute clone that is negative for BCMA. They become the major clone at time of progression, or what we see more and more often in almost 50%, 50 to 60% of therapy, especially post T-cell engager, the acquisition of this mutation in the extracellular domain of BCMA, and seems to be, as showing in this cartoon, that there is a specific hotspot in the BCMA extracellular domain where these mutations are indeed appearing, and I'll show you why this is relevant. So what we have done, we have actually functionally proved that each of these mutations in vitro, so creating cell line that express each of them this mutation. And I'm sure you have seen this cartoon before, but the point is we created cell line with different mutation. If you look, for example, in blue at the wild type, BCMA bind to all the different anti-BCMA therapy, Tecli, Erla, and Nanuctamab. But if there is a mutation, I'm just indicating the light blue cells carrying an S30 deletion, you can see Tecli absolutely doesn't bind to this mutation, while Erlanatamab and, of course, Alnuctamab, which I'm unfortunately not pursuing anymore, but was probably one of the best anti-BCMA therapy where we had. But so the presence of a mutation indeed give a differential response to therapy, and then, of course, this translates in different bind, different cytotoxicity. But why I'm telling you this story? Because I think we need to find a way to better catalog this mutation and eventually use a method to identify in clinic if these mutations are present and choose which therapy is the best for this specific patient. So what Dr. Lee in our lab has done and presented at the last ASH meeting, she has actually mutated to alanine any of these 50 amino acids that are part of the extracellular domain of BCMA. And what she has done, she has proven that if there are certain mutations that create what we call a cross-resistant to all anti-BCMA therapy. For example, D15, all the anti-BCMA T-cell engager are resistant to it. So no matter which therapy, they are all resistant. But if you have, for example, a mutation on C24, this mutant 21, we know Erla can be more effective than Tecli, and for R27 is, for example, Nuctamab more effective. So I will argue that because we have now access to so many of them, knowing which mutation is present in that specific patient can help us decide which anti-BCMA therapy to use. And this, of course, can help us personalize therapy and can also help to create better anti-BCMA T-cell engager. One last comment about the antigen escape, the mutation. The question I always get when I present the data about the mutation, are these mutations pre-existing or we are just selecting due to the therapeutic pressure of this specific patient? And so what we have done for few patients, we were able to, we had bone marrow aspirate collected prior certain therapy, when they were in CR, so when we were checking MRD and at time of progression. And what we did, we used droplet PCR, where we actually create primers specific for MA mutation, and we look if these mutant were present before starting and so on. I'm gonna just emphasize the attention to this case. So this is a patient that we knew developed two mutations, S30-DEL and P34-DEL, but you can clearly see before starting therapy, all the tumor cells had wild-type BCMA, so there was no mutation present. And then when we start collecting, checking the time of CR in MRD negativity, still no wild type was still present, but you can clearly see already here 6 months before full progression, we start seeing this 1.8% of cells with the S30-DEL or 0.113% of P34-DEL. Of course, this is a retrospective study, so we had another sample 3 months after. You can clearly see the clone increasing and became, unfortunately, the full clonal time of progression. So I will argue if we have a way to monitor for the appearance of this mutant clone, that will be the best way to do it, because then we could argue already at this stage we could have switched the target, maybe using anti-GPRC5D, and the patient will not have this progression. Last point about BCMA is also always consider the impact of soluble BCMA in response to therapy, especially in the era of anti-BCMA T-cell engager. We have shown that, for example, if we have high level of soluble BCMA, we can impair the ability of all the anti-BCMA therapy to bind to it, because we have really the sink effect of it. We have proven using clinical data that indeed the soluble BCMA is more than 400 nanogram per ml. These patients, they don't do well, and proven that probably a way to go around the high level of soluble BCMA is, for example, debulk the patient, use something else to reduce the tumor load, and then use anti-BCMA T-cell therapy. Or can we use gamma secretase inhibitor to reduce the level by just increasing the membrane BCMA density? And of course, in vitro, we were able to even overcome this by increasing the dose of T-cell engager, increasing the ET ratio that, of course, in patients will be more difficult. But I will argue it's a simple way that we can use in clinic to identify if patient we have in clinic can be a good candidate for this therapy. Now, in the last 5 minutes, I would like to mention what we know about resistance to anti-GPRC5D therapy. Not surprising, what we see with post-BCMA is very similar post-GPRC5D therapy. We see antigen loss, we see silencing of the locus of the GPRC5D, but I want to mention some update on some of the work we have done post-talquetamab. This is actually been just accepted in Nature Medicine, so will be soon out for you to read. And what we have done, basically, we have proven that in 60% of patients progressing on talquetamab, the cause of resistance is antigen escape to either a focal or large biallelic loss of the target, or the appearance of mutation in addition of deletion or not of the target or epigenetic silencing. But let me show you one case that actually illustrates very well what we're seeing. This is a patient receiving BCMA T-cell engager in 5th line, and then progressing after a year, where we know the cause of resistance was this clonal mutation of R27P. When she received anti-GPRC5D T-cell engager, she had an initial response of a year and a half, and then when she progressed, you can see that the tumor at time of progression developed 2 different additional mutations, D23N and TER. And what is shocking, and again, talk about the therapeutic pressure of the patient, look where these mutations are emerging from, exactly from the same clone that she actually acquired post-BCMA therapy. And this is the same clone actually showing by using this phylogenetic tree carrying this additional mutation, suggesting that indeed we are, with that strong therapeutic pressure, can eventually select for this bad clone their cause of resistance. Just one last slide about the role of this mutation on GPRC5D, and again, it's always nice to show that there is a mutation, but that indeed is functional relevant. So Dr. Lee in our lab have shown that this mutant, they affect the ability of talquetamab to bind, because you can see by confocal, all the mutant cells, they have the GPRC5D not expressed on the membrane, which is the case for wild type, but it's actually stuck in the cytoplasm. And indeed, this, there is no expression of GPRC5D on the surface except for one mutant. And because there is no expression, there is no binding of this mutation to the talquetamab. One difference is for the 2239N, which we have shown that they have a very similar effect or level at the protein level of a wild type, but when you incubate the cells with talquetamab, we don't see an effect, but we see some effect of furintamab because of its dual binding. And we think the reason is because it's related to the fact we know very well now how talquetamab bind to GPRC5D, and using in silico model, we proved that this mutation actually is able to alter the binding of talquetamab to GPRC5D by really breaking down this ionic interaction between the two that unfortunately changed the conformation of the GPRC5D, and this was the cause of resistance for this patient. Now, to wrap up, because I like to get eventually some question from you as well. So I have shown you, I apologize a bit quicker, but I try to summarize as much as possible the data in this topic. We know T-cell therapy are showing impressive results. We have seen them moving earlier with some encouraging efficacy. The combination, I will argue, they are also effective, but we all require longer follow-up to make sure that we can really use for our patient. I show you how the acquired resistance is mostly driven by antigen escape. This is mostly the case for T-cell engager, but also CAR-T. And we are learning how T-cell phenotype and the microenvironment is indeed important in impairing the ability of this therapy to be effective. So then, to conclude, I will suggest we have to think about strategy to improve efficacy for this therapy. So I will argue that based on the data I show you, we should probably monitor for the appearance of mutant clones, especially in patients receiving T-cell engager therapy. I will argue that it's mandatory for us to look for the baseline expression of BCMA, GPRC5D, especially if we're keeping the target, just changing the strategy for the same target. And of course, I mentioned earlier, but soluble BCMA is something we could easily implement in the clinic and see if we need to debulk the patient before starting anti-BCMA therapy. For immune fitness, I will argue that, again, because there is a lot of an overuse of the concept of T-cell exhaustion, let's look at the functionality of T-cells before calling a patient exhausted from the T-cell point of view. And then, of course, we are now methodology to study the microenvironment. Can the spatial transcriptomic help us to identify if the microenvironment is an healthy microenvironment or not? And eventually, if there is dysfunctional or it's immunosuppressive, we know that the IMiDs are a good friend in the sense they can actually help the immune system to perform better. And I will close by mentioning a few things that may come up during the Q&A part, but I think there are still a lot of unanswered questions. We still don't know what is the optimal duration of T-cell therapy. I talked to many colleagues, even last night. Each of us use T-cell engager with different timing. We stop at for different reasons. So we need to see data that guide us to identify the best duration of therapy for this patient. Secondly, I think we need to still discuss what is the best sequencing. We know T-cell engager work well after CAR-T, but can we do the opposite? There are data showing that we can, especially if we have at least 5 to 6 months post T-cell engager, just allow T-cells to recover. We are seeing data of using T-cell engager as a bridging therapy before CAR-T. Can something that, but again, data need to be, more data are required. And lastly, I will still argue that probably sequencing is better than dual targeting, but I have a hard time to argue that the tri-specific results are not impressive, but even there, longer follow-up will be required. And with that, let me just, of course, acknowledge people in our lab. They have contributed the work I show you today. Of course, Nizar Balis, many of you know, I'm leading many of the work I presented today. Dr. Lee was a superstar in the lab, and of course, all the other lab members collaborate, and of course, all of you for the attention. Thank you so much.
Thank you for a fantastic tour de force of all of the clinical data and scientific data for our mixed audience of clinicians and scientists. That was fantastic. So, Karthik.
Okay, one question maybe. Based on your observations of when resistance develop post-BCMA or GPRC5D, can you work out whether T-cell exhaustion is a driver or whether target resistance is the primary driver?
So in most of the cases, tumor driven by antigen escape. And the catch there is always, so first of all, these are relapse refractory patients where they may have the complex genomic instability that I think is contributing what we're seeing. And number two, we have been using this T-cell therapy very too often probably. So this was the time where we were afraid to give a pause, or even afraid if there was an infection or it's going to progress. So we were very aggressive. And therefore, we have created, without a doubt, all this selective pressure that allow this clone to emerge. Now, using earlier, or using pausing, or maybe doing maintenance earlier on, like after 3 cycles, for example, a patient in CR, we're seeing, we will see the data. If we just do every 3 months, are we going to see the same or not? But to answer your question, seems to be mostly driven by antigen escape, and this is also why we can use another T-cell engager in the next line of therapy, because again, the T-cell are still functional.
Jonathan.
Okay, sorry.
Yeah.
I think you've actually covered it. I was really going to ask a similar question about T-cell exhaustion, because I think clinically we find, even apart from efficacy, the amount of side effects and hypogammaglobulinemia and infections really are quite prohibitive, and they've been a challenge, especially with the BCMA-targeted drugs. So is there any sort of way that we could plan more carefully whether we can give patients pauses in treatment or 6 months of treatment, and whether we're actually doing them a disservice biologically by sort of causing T-cell senescence or exhaustion, and that we're actually losing efficacy, and we might get better efficacy by giving them 6 months of treatment, pausing, reassessing and restarting?
Yeah, this is a great question. So what we need is a more careful analysis of the TCR repertoire of this patient. We all have T cells on this, but what we are actually trying to see if by looking at their TCR repertoire, because I think what we're seeing, this is why we see infection in this group of patients, these T cells are too committed to recognize the tumor and allow really all the CMV, EBV to emerge. So unfortunately, I don't have a clear answer to your question. I can comment though that I think we should be we should just, going back to the question, don't be too aggressive, because then will allow just the T cell recovery, will prevent the T cell exhaustion, because even there is just the chronic antigenic stimulation that create eventually that phenomenon. But we will have some data, because we're analyzing the T cell repertoire of this patient.
Thank you very much, Dr. Neri. I think you very eloquently showed that the antigenic escape is the main problem. So I suppose my question is this antigenic escape occurs during the treatment, or are we pre-selecting clone that only exists before? I suppose that will mean that you can actually segregate patients to those who are having higher predisposition to genomic instability. And these patients are probably doomed to fail bispecific therapy in the long run, or is all myeloma patients are going to fail bispecific in the long run?
Yeah, so it's again going back to what I was in a way hinting during the presentation. So so first of all, the relapse, the tumor get more complicated, complex from the genetic point of view with the multiple line of therapy. I can share with you, for example, we know that there are NF-kappa B activation mutation often associated with the antigen escape, and that bring you to the point the myeloma cells become completely independent from BCMA and use NF-kappa B, for example, as a driver of the tumor. Then going back to your question, if there is no pressure, like therapeutic pressure, even if they are present and they can be germline, we actually have looked at one of the database, and some of these mutations are known to be germline, but if there is no pressure, there is no advantage of myeloma cells to start depending on it. So I think, unfortunately, it's the therapeutic pressure that is the cause of what we're seeing in terms of mutant clone. And what the point I want to make, and probably re-emphasize too, is because we know they are so important, can we just then look for it, especially if we are at the time where we are thinking to keep BCMA as a target, maybe go from CAR-T to cell engager. I think the one patient I presented was so eye-opening for us because it was a patient where we should have probably switched to GPRC5D, knowing that there was not even the target there. So the the one thing we are trying to, and many, who are working in that direction is let's create a panel that cover expression and mutation of the BCMA because it's the only way we can really reintroduce maybe another therapy against BCMA for this specific patient. Thank you.
Yeah, the microphone. And Jan.
Success.
So I'm struggling with this. So if the primary driver of resistance is antigen loss, so you talked about mutation, you talked about copy loss, but in between I think of transcriptional effect. So we've seen this before with cereblon, for example, as you treat, levels go down and down. So if you have a biallelic loss, 16q, and you have a predominant clone that is deleted, there is a very small amount of cells that are wild type still. If you leave that on, do you think BCMA will be re-expressed? The therapeutic, now that the patient is resistant, is moved on, would that small clone would re-express? The reason I ask the question is, I struggle with this issue of the myeloma cell expresses BCMA, and it needs it, and you have a therapeutic pressure, so it tries to lose it so that it can escape. So, but there will be a little bit of a trade-off. You need the protein, sort of the BCMA signaling for your survival, but for resistance you need to lose it. So how does the cell work out which mechanism will give it the best shot? In this case, you're showing mutation as a way to not get resistance, and you're also showing copy loss. So my question is, how does it work out, do you think?
So I can share from what other data that, again, we're working on and not presented today. We think we are learning how plastic these myeloma cells are. So they easily can adjust their dependency to other factors. So BCMA, we all thought was the perfect target because it's required for the biology of the plasma cells. And they're able to lose. Why? In some cases, they become dependent on MYC. They become NF-kappa B activating mutation are the one that we see most of patients with BCMA loss. Unfortunately, we are learning how the plasticity of the plasma cell allow them to just even lose BCMA. GPRC5D, even worse engine. So we see so much more frequent mutation because GPRC5D arguably is less important for a plasma cell. So I think we cannot deny how this plasma cell can evolve over time. And if I can share with you my concern of the tri-specific, going after two targets with the CD3 at the same time may actually be great for most of the patients, but the few progressing, they may progress with a double antigen escape with a disease that will be actually hard to treat. But time will prove if my concern is right or not, but I'm afraid that we cannot deny the biology of the plasma. Even with the venetoclax, right? We thought was a perfect marker for the 11-14, and we're seeing the resistant one, they become more B-cell-like, then venetoclax stopped working. So it's more that I think it's opening the question how much more we need to learn about the biology of this plasma cell progressing on post-BCMA.
Fantastic. And for people wanting to learn more about biology, there is a scientific session this afternoon where hopefully you will learn more. So I'd like to thank Paola once again. We have a certificate and a small token of our appreciation for you traveling all the way here to give us a fantastic talk. So thank you very much. It's now lunchtime. I've been asked to remind you there are multiple food stations in the hall, so please spread out so that you're not all in a big queue. The AGM is at 1:20 back in this room. After that, there are two parallel sessions, one in this room and one in another room somewhere, which is the Science Forum. I'm sorry, I don't know where that is. Portland room, the Portland room.